Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world. From border to border, coast to coast, and to all the ships at sea, I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning in to the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is Matthew Fusan. He's a Senior Vice President at SPH Analytics, focusing on product and client success. For those of you who are not aware, SPH Analytics is a true leader in healthcare analytics and population health management. They empower their clients to not only analyze, but also interpret their clinical, financial, and consumer experience data to maximize their performance. Matthew, welcome to the show today.
Thanks, Jim. I appreciate the opportunity to join you and go through some interesting topics today regarding MIPS.
You know, it is interesting. I know you've been deeply involved in the CMS's program, Macro MIPS, really since its inception. And fortunate to have you on the show today. Since recently, CMS released their quality payment program final rule. Now, I took a look at this document, Matthew, and it's over 2,000 pages long. So I'm going to be looking for you to help us become aware of some of the more significant areas we need to know about. So with that being said, let's just kind of kick off about the overview maybe of performance and exceptional performance thresholds and what impacts those changes.
Sure. So as anybody that's followed MIPS for a while knows that every year since it started in 2017, the performance threshold, and that's the point total that a clinician or group needs to accomplish to avoid a penalty, has gone up. So in 2017, it was 3 points, which virtually made it impossible to get a penalty, and that's been going up slowly. So we went to 15, 30. This year it's 2020, it's 45, and then really significantly for 2021, it gets to 60 points. So what that means is if you score out of 100, you score less than 60 points, you will see a negative payment adjustment on your Part B claims in the payment year, which will be 2 years into the future. So for 2021 performance year, the incentive or reduction earned will be applied in 2023. So at 60 points, that really starts to set the bar high in the sense of what's required for performance to avoid a penalty. So MIPS program has been going through a transition period for 5 years. In 2017, CMS put together a 5-year transition period where they could basically ease everybody into the MIPS program. And 2021 is the last year that that's possible. So we're going to see the performance threshold for 2021 set at 60 by CMS and starts to be a real meaningful number. There's really real work to be done to ensure that you're scoring above 60 and avoiding a penalty. The other threshold that you mentioned is the exceptional performance threshold. And that is set at 85 again for 2021. So for 2020, it's at 85, 2021, it's at 85. What that means is for any clinician or group that scores 85 or above, 85 to 100, you get to share in an exceptional performance pot of money that CMS has available to them, which is $500 million every year. So you score above 85, you get that money as well as whatever is redistributed from those that are paying into the program because it's a budget neutral program. So getting above 85 is really critical to maximize your score. And like I said, the 60 performance threshold that'll be in play for 2021 is a meaningful and potentially challenging number for people to get above to avoid penalties. So focus really needs to be put in place for MIPS if it hasn't already been for different organizations.
One of the things you mentioned was the MIPS score. And of course, this score is for Medicare Part B providers, and they score 0 to 100 is generated every year. So if next year somebody just doesn't do it at all, what kind of hit could they take on their Medicare Part B billing? What percent are they looking at penalty?
Great question. So if somebody were to not participate at all, it's a negative 9% hit. And if you do participate, but in the rule, this has been standard since the beginning, it's actually in the legislation, if you were in the bottom quartile, so if you were to say, okay, we got 60 points, and I'm going to score in the bottom quartile, so below 15 points, everybody in that world is going to get a minus 9% hit. So it's not just zero. If you were somewhere in that lower quartile, you're going to see minus 9%. And then that de-escalates, for lack of a better word, between 15 and 60. So it would be, 9, 8.8, all the way down to 0 is how the ramp will work there. But it is a very, very significant hit if you do not participate and do not have a hardship waiver.
That's one of the things when the MACRA-MIPS program kicked off, we knew that it was going to be incremental. The positive and negative reimbursement adjustments were going to be kind of small at first, but grow. But at some point, they're going to get significant. I think we're at the significant place now. And
I was just going to say, we definitely are. And part of what's been frustrating to people is the downside has continually grown per the plan, as you just said, but the upside has not grown accordingly. And that's due to a number of reasons. One of the reasons being, arbitrarily low thresholds for the performance threshold that CMS has set during this 5-year transition period. But we've seen, limited upside in the program for a number of different reasons. The threshold being one, of course, the impact of COVID, 2019. So even though COVID didn't start until 2020, CMS gave a blanket waiver that basically said in March, if you cannot submit data because you're impacted by COVID, you don't need to, you'll get a zero, not a zero score, a zero payment adjustment. So basically just neutral, as if you scored right on the payment threshold. What that did was contributed less money into the bucket for the winners. So the 2019 incentive payment was muted as well. So that's been a lot of frustration in the healthcare space by the clinicians and provider organizations of, hey, you keep telling me that I need to do this. You keep escalating the downside, but the upside has basically stayed flat.
Now, you mentioned the MIP score, and of course, we know the MIP score is based on 4 different categories. Can you touch on those different categories and if they're going to be shifting much, the percentage of what each category makes up of that 100 points next year?
Yeah, absolutely. So we'll kind of start off with quality and work our way through. So CMS in the role acknowledges, obviously, the pandemic and the public health emergency. You'll see a PHE. And because of that, they have put in place fewer changes. Some are, though, significant, but we don't see, wow, this category is changing a lot, this one, vice versa. So for quality, the category roles within the category don't have a lot of change. They've adjusted the number of quality measures available. It's been reduced by about 11. I think the number is about 209. So there's 209 measures available. And just interestingly, over the years, we've seen that number go from basically 290 at the beginning down to 209. So we're continuing to see the trend of them making that available bucket smaller, which I think makes sense. The number of measures available were so broad, and in our experience, we don't see a lot of people, leveraging all of those. So fewer quality measures, but not significant. The complex patient bonus, which has always been in play for the last few years, and it's typically 5 points. So they use HCC scores to determine how complex your patient base is, and then they give you a bonus of between 1 and 5 points. Well, for 2020 and extended into 2021, they have made that 10 points. And that's a way that they're trying to help from a COVID impact perspective. So HCC scores, HCC coding, very important. So it is in many, many worlds, but also for MIP. And then the biggest component is the category weight shift. So when MIP started, cost was not in play and quality was, and it started at 60 points. Over the past couple of years, that's been coming down. And for 2021, the quality category will be 40 points instead of 45, which it is now. With that, I'll jump to the cost category because that's the other component that is going up to match that difference. So the cost category, no changes. The same cost measures that were in place or are in place for 2020 are in place for 2021. Those measures are being updated accordingly with the drastic changes that we've seen this year related to telehealth and remote health, for lack of a better word. But other than that, category doesn't change, other than instead of being worth 15 points of your total score, it goes up to 20 points. And then with the performance year, with the transition period ending after 2021, by law, those two categories got to each be worth 30 points for 2022. And the challenge that creates is CMS provides no feedback during the performance year on those cost measures. So everybody's kind of flying blind. And when that was 5 points, it was a frustration, right? Now that it's at 20 points and soon to be 30 points, it is a really, really valid, meaningful concern from everybody that 30 points of my overall score in 2022 is based on something I have zero transparency into and understand how I could potentially drive improvement. So for 2021, the key is 40 points for quality, 20 points for cost. Very little change within either of those categories. And then we have the other two, promoting interoperability. Little change in that category, remains 25 points of your total score. They're adding a new HIE measure that organizations can choose to leverage. The trick there is it's not only consuming information from an HIE, it's bidirectional. So need to be able to show proof that you're consuming and pushing data to the HIE. Other than that, that category stays the same. And for improvement activities, stays the same as well. So 15 points, almost no changes to the available improvement activities, which hovers right around 100. And you still have the requirement that started this year and will carry into next year, which is that 50% of your clinicians must accomplish the same improvement activities at the same time frame. For smaller organizations, that's not a huge deal, but we know from interacting with people in the field as well as our clients, doing that for larger organizations, especially multi-specialty organizations that have scattered across a geographical area, hitting that 50% bar has been a real challenge. So IA doesn't change, but that requirement for 50% stays in place, and we're seeing that be a challenge this year. We assume it'll be a challenge for people next year as well.
Of those four categories, three of them, promoting interoperability, kind of a new term that more or less correlates with what we used to call meaningful use.
That's right.
Quality reporting and improvement activities, that's data that has to be reported to CMS. And so it seems like there's been some changes in how that data can be submitted, particularly around what was known as the web interface method. Can you bring us up to date on that, Matthew?
Absolutely. So in the proposed rule, and this was shocking to most everybody that I know, including myself, when it came out, CMS said, we are no longer going to use web interface as a reporting method, starting in 2021. Now, in the final rule, they've relaxed that, and they're using 2021 as a transition period. So you can still use it in 2021, but it will be gone in 2022. The big impact for web interface submission is generally around the MSSP ACO program. So for non-MIPS, yet ACO program, every ACO that was running was submitting their data, and this is basically track one, non-two-sided risk. Things change a little bit, but that's who most of the ACOs are in the country. They submitted data for ACOs through web interface. That data was then also used to score them in MIPS. So if you're in an ACO, but it's only upside and no downside risk, you still participate in MIPS. So now all the organizations, and there are non-ACO organizations, typically large groups that have consolidated smaller practices, and everybody's on different EHRs, which makes it a challenge to bring and aggregate that data. Web interface was an opportunity for them to submit without having to do that. So In 2021, you can still do it. But why this is so important, and we're talking about it even though it's not going to be official till 2022, is this is a massive operational change, especially for ACOs, but as well as anybody else that has been using it. Now you get into a lot more data aggregation type questions. So there is a new method, let's call it, or model that they've introduced called APM performance pathways. So APP is the acronym. That is what will be the go forward submission requirement and structure for ACOs. They can start using it in 2021 if they would like to. They will be forced to use it in 2022. And that has a CAP survey as part of it. It has 3 CQM or ECQMs, and then 2 claims-based measures. For those 3 CQM or ECQMs, now you need to make decisions. Am I going to have each 10 submit that data themselves, and then CMS will take it and roll it up? That creates some blind spots in how am I performing and how am I doing over the course of the year if it's not being rolled up, consolidated, and viewed across the ACO. So then I get into, well, do I build interfaces to get that data? What are my options? So there's real strategic and operational decisions that need to be made, which is why CMS gave the transition period, because to expect people to do this in less than 6 months was really crazy. If you're not in an ACO, but you use the web interface option, come 2022, you will have to do what everybody else does, which is ECQMs or CQMs. You'll likely be too big to do any reporting through claims. So again, it's big changes that people need to think about, understand the operational impacts, and then put solutions in place for. So we'll see how many people choose to change this year. My guess is it'll be a low number, but come 2022, it's a pretty significant change. For IA and PI, the other 2 categories you mentioned, they are getting stricter on the auditing of what's submitted. So that is essentially attestation based with some data. And what CMS is now saying, anybody that submits that data has to audit it and ensure that it is valid. So that creates a new wrinkle and a new overhead that didn't exist before. So same method of submission, but now some additional work that needs to be done to audit that data and ensure its quality.
Something just popped in my mind. Thinking back to the Meaningful Use program, there was a fairly dynamic audit program in which detailed documentation had to be produced, or your EHR incentives were returned. Under the Macro MIPS program, have you been aware of any audits yet?
There have been a few. It doesn't seem exceptionally widespread, at least from what we've seen. But then, of course, COVID has come along and disrupted that. So the audit potential is real. It is similar to, like you said, with Meaningful Use. I think they were kind of giving people a little bit, again, through this transition period, first couple of years, maybe not being as aggressive with audits as we had seen them be with Meaningful Use. But we started seeing an uptick there. And then, of course, COVID hit. So I think that's had a material difference. But the message that all of our clients, and part of what's built into our software is an audit locker, which essentially stores all the data and all the information, because you absolutely need to be prepared for that audit. We operate under the model with our clients that you should assume it will happen, and therefore you'll be prepared if it does, right? It's always a little insurance policy, basically.
Absolutely. There's so many acronyms in all these CMS programs, and one that we've come to learn a little bit about in the last year or so is MVP. Can you tell us what the MVP is and whether it's being delayed?
Yes, so MVP is MIPS value pathway. It was introduced as a topic, or a concept, I should say, in 2019. It was originally slated to start as part of the MIPS program in 2021. CMS decided, due to COVID and honestly some structural work that needed to be done to pull it off, to 2022. So personally, I think COVID gave them excuse to bump it to 2022. I don't think they were going to be operationally ready to do it anyway in 2021. What the concept is behind it is, MIPS has not been super popular with everybody out there, as you would imagine, especially with a flat upside that has not been what was promised. So they're taking feedback, and to CMS's credit, they've been willing to adjust this program based on feedback and learning. And this is one of those adjustments. So a MIPS value pathway is going to be a specific set of measures and boundaries based on care that is delivered. So we could use an example of diabetes care. So if I'm a clinician and I provide diabetes care, I would use the MIPS value pathway for diabetes. And that way, then I'm not choosing which quality measures to use. It says, here's the 3 measures that you will use based on this pathway. It introduces a couple claims-based population health type of measures. It says, here's the improvement activities that you will use as part of this pathway. And then PI stays the same. So CMS's goal and objective is a couple things. One, reduce clinician burden. So the concept is, instead of all these choices, which was originally viewed as a positive, is now being viewed more as a negative. And we're going to say, okay, here's what matters. Here's what you're going to be scored on. Secondly, and really importantly, from a patient perspective, it is now if I need diabetes care in a particular area and MVPs are in place, and I go to Physician Compare, it actually has an updated name that I can't recall, but everybody knows Physician Compare. I can look at these 2 individual clinicians and they are scored on the exact same thing. So now I'm comparing apples to apples. In today's MIPS world, if I tried to do that, 1, I would not be able to dial it down into such a level of care, but 2, each group can report totally different quality measures, totally different IA activity. So it's not an apples to apples comparison. So they're trying to get to a point where it's better for the clinicians, but meaningfully really better for the beneficiaries for how they select care. It's going to be a slow rollout is the other thing. So the way that they're going to build these, and they put more guidance and parameters around how you develop an MVP, who's involved in signing off, because you can imagine there's a lot of stakeholders that have an opinion as what should make that up and which clinician types should fit into which types of MVPs. So they've expanded on those guidelines in their final rule. I think it's probably a 3 to 5 year rollout once they actually start. In the first couple years, the vast majority of clinicians will still participate in what they are now calling traditional MIPS. So it's coming for sure. Still a lot to be seen about how they are going to execute it from an operational perspective. But it has been delayed until 2022.
That's one thing we've learned, Matthew, that we're always seems like waiting for further clarification and guidance. The time is, our time's flown by. We only have about 2 more minutes, but before we run out of time, please touch on something really important, which is the COVID extreme and uncontrollable hardship extensions and exclusions. What are we looking forward for
Absolutely.
2021?
Yep. So CMS had come out a little bit earlier this year, said it was in place for 2020. They have finalized that, and they have also in the final rule said it will be in place for 2021, now with the knowledge that this will definitely roll into 2021. It's something that needs to be looked at very strategically, and each group and clinician could be different. There would be times where it makes sense to take that for sure. What we are counseling is don't think of it as a blank slate and just say, hey, I got an out, I'm taking, for a couple reasons. One, you already got the operational train running. If you do internally, you got your clinicians on board. Part of what clinicians hate is constant change and back and forth. Then you'd say, hey, we're not going to worry about this for a year. Then 2022 hits. Now you need to execute. And by the way, the threshold to avoid a penalty in 2022 is probably going to be between 70 and 75. The downside penalties are going to increase. The upside should increase. So there's lots of reasons. And if you can score above an 85, you definitely want to tap into that money. So everybody should know it's available to them. You can pick and choose different categories to submit. So it's not an all or nothing. It can be, but it doesn't have to be. And also really got to think about the ramifications if you pull that trigger. You could choose to keep operating, just not submit. So out there, and what we're counseling is really think through all the impacts before you go ahead and do that. That is also something that could be audited, obviously. We don't know how aggressive CMS would be with it, but they can audit and say, prove to us that you couldn't submit your data because of COVID.
Yeah, that's one of those kind of uncertainties. Well, with that being said, that's probably a pretty good time to wrap things up. To our audience, Thanks for joining us on this episode of Tate Chronicles. I offer a special salute to my guest today, Matthew Fusan of SPH Analytics. Matthew, thanks for coming aboard today.
Thank you for having me.
You can find more information about SPH at their website, SPHanalytics.com. I'd also like to mention that they are hosting a live webinar on Tuesday, December 15th at 2 p.m., covering even more details of the QPP final rule. I'm sure to be recorded, so if you can't attend live, you can go back and listen to the recording. You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.